All right, so we might have the panel discussion. I think I've been tagged in as moderating this one, so we might get that started. So obviously we've had 4 amazing talks covering a lot of great ground. Did anyone have anywhere we wanted to start? Yeah.
What fantastic talks. Michael Woodward, and I'll be having the pleasure of talking later on today. Rama, I'd like to ask you, seeing as how we've basically eliminated those 13 serotypes in the herd, i.e. humans, in Australia anyway, why are we still recommending that for 70-year-old adults? Why don't we use such as the Merck VP116 vaccine, which mops up all the remaining, or many of the remaining serotypes? Surely that's a logical decision.
Yeah, eliminating a provocative question, thank you, but eliminating those serotypes is probably not the right language I would use. We're probably suppressing them very well with the vaccines we're using. I think we're providing a good amounts of herd protection through that childhood population-wide program. I think augmenting that with additional usage of that vaccine in the older adults is also sensible. And I think thinking laterally and thinking about the other I suppose tools in the toolkit we can use. Particularly in other age groups, is important. I think the missing part of the story, though, ultimately is what serotypes are causing disease, particularly pneumonia, in older adults. And if we can really get high resolution of that part of the story, I think we can be a lot more, specific about, I suppose, putting legislation in and funding those products to interrupt disease in that part of the population.
Thank you. Caroline, you were talking about point of care testing and the great advantage it is to know straight away what the diagnosis is. I guess the question that your experience has showed us we can manage diseases better, we can do isolation control, all that sort of stuff. So why do you think point of care testing isn't universal? Why do we have to rely on institutions that are sort of a collection and then sort of line up and do it? Shouldn't point of care testing be available to actually manage any disease that we can do a point of care testing on?
Yeah, I think that's a good question. I think a lot of sporting organisations now that they've become affordable, the machines, and the new BioFire is a very tiny machine that's very easily transportable. It doesn't have the ability to do the gastro panel at this stage, so we're not looking at that yet. But I think it serves a great purpose in that regard. And when I think about our Olympic athletes, like none of them would have gone to the polyclinic to get a formal PCR test. One because it would have taken 24 hours to come back, but secondly because I think it's an organisational thing. I know in the Pan-Pacific Games, they actually retroactively decided that people with COVID couldn't compete. This is after they'd said they could. And so people that got tested were then eliminated. So I think there's a lot of fear about doing it outside. And I think, it has, to me, at the Australian Open, it's paid for itself time and time again, just with that norovirus outbreak, with the, 60 minutes after our first toddler had a loose stool, we had an answer. And we could implement infection control strategies, which I'm sure help with the spread of that too. So I think they should. I think it's a cost issue maybe, and maybe it's not as widely known in certain settings. I think they used it in a lot of outback communities during COVID.
Professor Robert Boyd did some work in nursing homes in Sydney, Queensland, and showed that you could, if you identify an outbreak early of influenza. So just before COVID, we were starting to use point of care testing in nursing homes, and with 20% reduction in severity and numbers of people and treatment earlier. So we feel it's a political maybe barrier rather than because the technology says we should be doing it. So thanks.
I've got an online question we might just quickly step to. So how to manage vaccination challenges in children when only one parent consents? This is a growing problem post-COVID. Is one parent consent enough? Anyone want to tackle that one?
Yeah, conveniently I work on the New South Wales Specialist Immunisation Service, and I suppose I do see in clinic a number of hesitant families and parents for that matter. So yeah, it's usually trying to discuss with that I suppose the hesitant parent and try and understand the motivation or rationale for why they're hesitant. I think in generalisation, to generalise, you see a whole spectrum. You see some people that are quite fanatical and you're not going to change their mind, and so that's going to be a very difficult situation, or it's probably a very difficult dynamic within the family unit for that matter. And then there's other people that, for whatever reason, past experiences and so forth, are probably just wanting to hear from an expert the pros and cons of vaccination for their child specifically. And so it's trying to understand where they're coming from and provide information accordingly. Sometimes you need to refer them up the chain and put them in the right setting so they can hear that information from someone. If they continue to not consent, again, it's difficult. As a provider, you can't vaccinate that child if they're clearly there, present in front of you, and not consenting. I think practically, though, if a parent turns up, a single parent who is consenting with their child, it's not routinely asked whether the other parent is consenting to have that child vaccinated, and so usually they will go forth and vaccinate in that context.
Okay, thank you. Luke?
Luke Spence, I'm from Mater Hospital in Brisbane and University of Queensland. A question and a comment. The first question is regarding whooping cough. Given that the significant burden now appears to be shifting, more towards the adolescents and particularly kind of that 11, 12, 13 age group, and knowing that the acellular pertussis vaccine, the waning immunity by 5 years is virtually non-existent, aren't we kind of, shutting the gate once the horse has bolted? What are your thoughts on actually bringing the vaccination, to maybe 8 years of age or something like that? That's the question. The comment is, Caroline, in a previous life, I worked with one of your colleagues, Peter Fricker, and in the early 2000s, they did a case cost analysis from the 2000 Olympics where Matt Shervington was suffering from an upper respiratory tract illness immediately before the 4x100 metre relay. And Australia got knocked out in the semis. We got disqualified, but Shervo's performance was terrible. And they estimate that it was probably about $800,000 in terms back then of money lost. And that's when we started pushing for we didn't really have point of care testing PCR back then, but at least getting PCR on site. And then in 2011, I was talking to Richard Budgett, who's now the Chief Scientific Officer for the IOC, and talking to him about getting that for the 2012. And the appetite wasn't there because they said it's not really going to be much of a problem. And it was. And so, but now, COVID has changed everything, but now it's great to see that, infectious diseases and respiratory, they're all kind of coming together in the sports medicine field to, utilise our technology and our expertise, particularly, as Australians, we love our sport, and if we don't win, we want to know why.
Excellent questions. We might start with a pertussis question first.
Before I go into Pertussis question, I just want to add something to the vaccination thing, which Rama mentioned. So when COVID vaccine was going to be implemented, and it was not at that point even designed for, it was not even recommended for children, what we did was we talked to parents and carers who come to our hospitals, hospital network, Randwick and Westmead, and repeatedly it came that they would take the vaccine for their children if it was recommended by their doctors. So I think what Rama mentioned, talking to our parents and explaining really helps if we have, because globally, only 5 to 7% people are vaccine hesitant. Majority of the people actually want to take the vaccine if the right information is provided to them. So I think that's very crucial that we engage with our consumers, with our stakeholders. And going back to pertussis, I really don't have the answer to that question, and I don't think there's any country where there's that strategy being employed, but could be a strategy, particularly because of the waning immunity and the acellular vaccine. be an option to try out and see what the real data suggests, but I really don't know the answer to that question, sorry.
Air quality again, Bronwyn. Patients are becoming a bit more aware of that and asking their GPs, and the GPs want to know which air quality purifiers work well in the home environment. But that gets them thinking, and I know that Victoria is looking in nursing homes with Brendan Crabb and your colleagues to look at the quality for that, and that is a big issue given the low levels of vaccine boosterage. What studies are going on there and what impact is it having? So two-part question, what air purifiers might work for the rank and file, and if you're in an aged care facility, what impact is the air quality, the air purifiers having in terms of reducing their infection load?
So, first question first, in terms of which air purifier for just a general person in their home, is that what you're asking? There's some great resources out there. There's a website called Clean Air Stars, which is run by experts from Australia and around the world, and it has this brilliant little calculator you can put in terms of how big your room is, how many people are typically in it, and you can work out how many air purifiers, and it suggests, like, you need 2 of these ones, or you need 1 of this one on the high setting. One thing you do need to be aware of is the noise sensitivity, and this is one of the problems in schools. You're much better off to have 2 smaller air purifiers at a medium level rather than 1 super loud one, because, in Victoria, unfortunately, we just purchased these one-size-fits-all very large air purifier. Many teachers stuck it in the wall, it turned it on, it was too noisy, and they turned it off. But anyone who actually wants to know, this is it, we need to get that information out there. That's part of our public education campaign. That's exactly what we're finding. People have got really good questions, but there aren't sort of government-anointed resources to help them. The good news is that there are many, many different varieties of air purifiers that will do the job. There's even there's nice designer ones if you're quite aesthetically focused. My sister is in that category. She has her house fitted out with sort of Danish designer air purifiers, which work beautifully. Even IKEA makes some really good ones. They're cheap, Target, really cheap, and you can get them. So there's many really good ones. In terms of aged care, so yes, air purifiers are in some aged care settings. However, the hearing issue is big in aged care because many aged care residents are hearing challenged. Masks are not great because they can't see your mouth, and often they're relying on that. So we need to make sure that aged care settings have a lot of fresh, natural air coming in, open doors and windows when you can. If families are meeting, if they can meet outdoors, that's 1,000,000 times better than breathing those bugs indoors. But the study Burnett are leading with the Victorian Government support is on GUV, germicidal UV radiation, as a better response to all those challenges in aged care. Wouldn't it be amazing if just this light that we're not even thinking about, it's not noisy, and it doesn't cause any it's not a trip risk, that's the other thing. You're plugging in those air purifiers, so you've got to be careful you don't trip over them. In aged care, that would be disastrous. So GUV is probably the solution that people are going to look at. The study's already started. There's only a 1-year study in 60 different aged care settings in Victoria, and we'll have the results by the end of this year.
I think your mark may not be.
Oh, really?
Yeah. And I've just got an excellent online question from Raina. The case fatality of nosocomial COVID is orders of magnitude higher than in the community, and as far as nosocomial infections, COVID eclipses all others, so wound, AMR, etc. What can we do to reduce the high rates of nosocomial COVID? Can we add it to the suite of quality measures for hospitals, and how could this be done? And I guess I'll get everyone's sort of take on that one. So Bronwyn, if you wanted to start there.
Sorry, I hope anyone heard me before. Look, I agree. Is that Raina?
Yeah.
Raina McIntyre, the great Raina McIntyre. So I agree. I think that nosocomial COVID infections are something that should be our urgent attention to fix. People should go to hospital to get better, not to get an infection they didn't have that is having a 5 to 10% death rate. I think that is just totally unacceptable for the Australian community. What can we do? I think there's many measures that need to be taken. In particular, we need to make sure that we have very robust airborne controls in our emergency departments. I think they're probably the biggest risk area because clearly sick people come in and people who have respiratory distress clearly can't wear masks. So we need to make sure that our staff are well protected, but also all other patients are well protected. So we really need to uplift indoor air quality standards in emergency departments, but also throughout the hospital. I think there's this misunderstanding that hospitals have excellent indoor air quality standards, except for some theatres where surgery is being performed or some negative pressure rooms. That's not the case. Most wards have no particular indoor air quality standards at all, and most of them, because they're big buildings, are in completely sealed environments where you're entirely reliant on mechanical ventilation. So I think in the short term, we need to get air purifiers widespread in hospitals, and not air purifiers that are not plugged in or plugged in but not turned on. We need to partner this with an education campaign to make sure our healthcare workers really understand what is going on in hospitals and how we can serve our patients better. We also need to really come back to some basic principles like the Hippocratic Oath, do no harm, and also like the Australian Charter for Healthcare Rights. There is a Charter for Healthcare Rights as a patient, and every patient has the right to be treated in a safe environment. And I personally think we're in breach of both of those principles at the moment, and we just need to return to the basics and really advance air quality and airborne protections in hospitals. And it won't just be for COVID, it will benefit every single airborne disease.
Excellent. I'll just ask the panel if they have any final thoughts on that or anything else we've chatted about. No? Excellent.
I simply was just going to echo some of the thoughts around point-of-care testing, particularly in the hospital environment. I think cohorting, particularly during peak respiratory illness season in New South Wales, is an issue. We get huge backlogs in testing in our central lab, and I think we definitely see quite a number of cases of transmission within the hospital environment just because of that. We see a lot of children go home before they get their swab results back because it's taking days to get a basic PCR result back on a swab because we've got thousands of samples to process. And so at least trying to be able to get quick results where we can identify the needs around cohorting children in the hospital environment, I think is a really important measure to try and instill.
Great. I think it's a really good point to finish on, especially when the technology is there and available. So please join with me in thanking our 4 fantastic speakers.